You know what else happens that drives me crazy? I could go off on this topic.
Let's go up. So we always end the beauty outlaw with champagne.
Oh, heck yeah.
We're going there.
We're going to go there.
Welcome, everybody, to the Beauty Outlaw podcast.
Hello, everybody. Welcome to an awesome episode of the Beauty Outlaw today. Today, I'm excited because I have been trying to get Dr. Husain on the show for, I think, over a year. We've met several times, and I've been able to listen to him lecture and speak. So let me give you a brief overview of who this person is. This person's pretty special because we don't have a lot of, I think you're triple board certified cardiologist. Am I correct?
Yes, that's correct.
Okay. And he has taken the merge over into integrative functional medicine, which means he wants to prevent heart disease before it happens. And that's, I believe that's his goal and his ambition. He's an amazing speaker. I look at him as somewhat of a mentor because there's not a lot of information out there. And we get some great information in the world of longevity at our conferences, and doctors like Dr. Husain are really forging forward for us new providers out there that really want to help people prevent heart disease. So there's been a lot of talk of this all over the internet about our Lipo-A and cholesterol and what it means and what it doesn't mean. And now we've added layers of these growth peptides that could actually interfere, possibly or not. And we're going to get into this today. I also want to tell you a little bit about him. He's an athlete. He takes care of himself. You're an outdoorsman, and he's a painter as well. So he's really well-rounded, super smart and intelligent, and the leader when it comes to cardioprotective health, female health, men's health, and I'm going to just pick his brain today. So I have a ton of questions. I get these questions from my patients, and I'm super excited. Welcome to the show.
Wow, thank you, Jerry. That was a fantastic intro. I think I need you to come on and introduce me next time I'm doing a lecture.
There we go. I'll be your cheerleader because I am your cheerleader.
Thank you.
Because people like you can actually help people like me with our patients, and also just the rest of the world out there, because heart disease continues to be the leading cause of death for men and women, I believe, in the United States.
Yes, and globally. It's
Globally.
continuing to grow globally as well, because the global population has decided to adopt some of the eating habits of the United States and the industrialized world. And so that leads to more processed food. It leads to more seed oils, more higher carbohydrate diet, and just a higher caloric load. So all of that just contributes to this growing tide of diabetes, atherosclerosis, obesity, and then that's what is the seed for all of the cardiovascular risk factors.
Absolutely. It is frightening, to tell you the truth. So it's not just our old risk factors anymore, right? Like we're smoking. That doesn't even matter anymore. I mean, it does matter. I don't mean it doesn't matter.
It's a risk, sure, but it's not the only thing.
It's not the only thing.
I think that brings us to a very central message that is still relevant in the cardiovascular preventative space. It's the thinking that there's a singular thing that prevents cardiovascular disease. In the past, it was, okay, I stopped smoking. Why am I still having heart attacks? Well, it's not just your smoking. Now it is LDLs. Oh, my LDLs are at 55, lower. There's a study that says I should have it at 25. Why is it that we're still seeing people with atherosclerosis? Because it's a highly complex disease that requires multi-system thinking and multi-system approach to treatment.
And that's where you come in. And
Yes.
we're going to start with some, my mentees that listen to me, my nurses, that I could help educate them a little bit more on cholesterol itself. And the patients listening today, my patients that were doing peptides, and some of them aren't allowed to do peptides. And there's reasons why we don't do that. And one of those reasons is they're in their labs and their cholesterol and things like that. Can you explain, let's talk first about how cholesterol works in the body and its importance. What does it do for us?
Yeah. So the particle, the LDL particle, well, let's first start what happens when you eat something, right? Let's start with the basics. We eat something, we take something in that's a fatty meal, maybe it's a healthy meal. The gut digests it, grinds it up, puts it into the portal circulation, and that goes to the liver. The liver repackages that. And the fat particles that go from the gut to the liver are chylomicrons. They go to the liver, that gets repackaged, and those become VLDLs. Now, VLDLs are the parent compound that becomes LDLs. All right, and then it also repackages it into HDLs. So every time you make one VLDL particle, that one VLDL particle eventually becomes an LDL, and that particle has ApoB. ApoB is the structure that it contains all of what's the cholesterol and the triglycerides inside. So you've got two things inside there. You've got triglycerides and cholesterol in the VLDL. As it goes through the circulation, your body will take triglycerides out of it and some cholesterol, but predominantly triglycerides. And that will change the shape of this particle from a VLDL, very low density lipoprotein, to an intermediate density lipoprotein, to a low density lipoprotein, the LDL. And that's what sticks around in the circulation longer. And because it sticks around in the circulation longer, it's more associated with plaque. Those other particles that become LDLs are still associated with plaque, but they don't last very long. But sometimes in different populations and different people, those other particles do cause an impact. So the one thing that's consistent is the ApoB particle. And so that's why ApoB is a better measure of how many particles are potentially causing atherosclerosis, because it's assessing the VLDLs, ILDLs, and LDLs. And it's the number of potential particles that hits the arterial wall. An LDL number that you get from the lab, the only thing that tells you is the amount of one particle, the amount of that one component, the cholesterol that's in the LDL particle. So it's eliminating a lot of the other factors that can contribute to atherosclerosis. Now, why is the body doing this? Because those triglycerides are going to be used to deliver potentially energy. You know, triglycerides are used by the muscles to burn for fuel. It's going to be used for cell membranes, and same thing with the cholesterol. So we need a balance of these things. We need LDLs, we need cholesterol, we need triglycerides so that it can deposit into the cell wall, maintain fluidity, but we also don't want it to be too high, because if it goes too high, it overwhelms the arteries, and it can overwhelm the cell membrane too, because then we get an imbalance of the type of cholesterol and triglycerides in the membrane, and that can cause problems too.
It's complicated.
It is complicated, yes.
It's complicated, but overall simple, and that's what I think the ApoB has gotten so popular now, is because now it's trending everywhere and is an important factor, I think, to run in your labs. And guidelines, mainstream guidelines in modern medicine, they don't run that as much before they make the decision to medicate.
Yeah, someone. They don't. The mainstream guidelines still focus on LDL particles and our LDL measurements, and I think that the reason is because it's more easily accessible. It is something that most doctors are trained on how to interpret. ApoB is not that different, but it's a much more validated and accurate measurement. And this is validated by many studies, and it's accepted by most governing bodies in cardiology and lipid management. And if you look internationally, it's what they recommend as APO is to guide cholesterol lowering therapy, and American associations do as well.
Now, we also have something that's trending now, which is the other guy, which is the lipoprotein A.
Yes. So lipoprotein little a.
Little a, baby A.
Lipoprotein little a, it is another protein that sits on the outside of the LDL particle. Now, what this protein does is it will block the ability of your body to break down fibrin or to break down blood clots. So it makes these blood clots stick around a little bit longer. All right, that little ApoA particle is similar to that compound. It inhibits your natural compound from being able to break down blood clots. Why is that important? Basically, apolipoprotein little a is a stickier and more inflammatory form of the LDL. That little protein makes the LDLs become more problematic. So there's a lot of attention being brought to this because it's genetically determined. There's very little that you can do from a diet and exercise standpoint to lower it. And in fact, there's really only a few medications or lifestyle changes that even move the needle a little bit, which is why the pharmaceutical industry is really looking into different medications that could potentially reduce it. Now, many studies have seen an association between apolipoprotein A, LP little a, and increased incidence of heart attacks, atherosclerosis, valve disease, even venous thromboembolic disease or blood clots. And so there's an association that's been seen, which is why it's getting a lot of attention.
So Big Pharma is actually working on something that can help lower that particular number, but lifestyle itself and those modifications that we can do personally don't really touch that. It really just shows we have a risk factor, a propensity to atherosclerosis.
Yeah, but I will make a caveat to that because there's very few things that lower the number itself. But what we have to remember is that the number itself is not necessarily going to determine that you have atherosclerosis. What you have to remember is that this is probably a risk amplifier because there's plenty of people that have elevations of LP little a and they don't have accelerated disease or they don't have premature disease. So why is that? It's because most likely they've already controlled all of their other risk factors. So when I say that there's nothing that lowers the number of LP little a, that's true, but the risk will get lower if you do all of the same things you need to do to control your metabolism, to eat healthy, exercise, and do all those lifestyle changes. So having an LP little a elevation is not an excuse to not do your job to live healthy.
I love that you addressed that. That's great. I love that because it is important. That's because if we can control the ApoB, we can control that, right? And we can do that through sometimes just plant sterols and lifestyle, metabolism, things like tirzepatide. But we can also do it with medications. Yes. Right? And sometimes that's important. Statins.
Yeah. I mean, in the right patient population, we need to use those. If you've never had an event and you're what's called primary prevention, meaning preventative, then we have to really consider whether statins are right for you. We have to look at your lipid profile in detail and look at your risks because we've been overtreating. Maybe we haven't been targeting the right population because treating everybody is not necessarily what we need to do. But if you've had a stent, if you've had a heart attack, if you had open bypass or open heart surgery, then you've already fallen way down into the spectrum of heart disease, and you will probably need pharmacologic therapy. Now, that could mean a statin, that could mean a PCSK9 inhibitor, or it could mean something like bempedoic acid, which is a newer lower cholesterol lowering medication, and it works in a similar manner than statins, but has a far better side effect profile and probably metabolically better too.
Is that, which one is Repatha? Are any of those Repatha?
That you mentioned?
Repatha is a PCSK9 inhibitor.
Okay.
So, yeah.
Okay.
So let's if you want me to, I can break it up, kind of loosely what these each do. Statins block the production of cholesterol in the liver, and they improve the receptors that pull in LDLs. The biggest issue is that statins work in multiple tissues as well as the liver, and by blocking the production of cholesterol, it blocks other things like CoQ10, vitamin D, changes, magnesium dynamics, things like that. But it has profound anti-inflammatory effects. In that same pathway, but 2 enzymes higher, is bempedoic acid. That works on the same pathway, which is called the mevalonate pathway, but it focuses just on the liver. So it doesn't go to the muscles, it doesn't go to other tissue like statins do, and doesn't have those side effects. And it's not as potent of a blocker. So because of that, it doesn't have as much of a side effect profile like the statins do, and in fact is better tolerated. And then what you mentioned, the Repatha, is a PCSK9 inhibitor. That doesn't change any of how you're making cholesterol, but it improves how well your body pulls it out of the circulation. So it doesn't reduce vitamin D, it doesn't reduce CoQ10. It may not affect mitochondria, but it will reduce the amount of circulating cholesterol or LDL in your system.
Oh, interesting. I didn't know exactly how that worked. So thanks for explaining that.
Sure.
I know it's very expensive.
Mm-hmm.
So I know in primary care, we don't, it's not something we recommend a lot because of people's affordability and things like that. But I think it's getting lowered, and especially for people with heart disease.
Yes.
Like my father. My father has heart failure.
Yeah. That's for the right population. If you have peripheral vascular disease or heart attack or atherosclerosis, depending on the insurance company, they are starting to become better with their coverage.
That's great. Okay, are you trying to optimize your health, especially your lipids? Are your lipids running a little high when you get those numbers back? I love this supplement. It is so therapeutic to help lower those LDLs. It is citronal LNA from New BioAge. So at checkout, use the code TheBeautyOutlaw and you get a discount, and they'll ship it right to your house. I love this. I take 3 one time a day with food, and it has helped lower those lipids. Thank you, New BioAge. So with all that kind of interesting and not sometimes bad news, what can we do? Somebody that's listening right now that's a little worried because their lipids are raising because they're perimenopausal or they're aging. And hey, right before we do that, why don't you tell us why our numbers go up, our LDL goes up when we are in perimenopause or postmenopausal, or we're just the aging male as well?
Yeah. Well, when you're going, women have gotten a bad rap for so many years in the United States, and part of that is the Women's Health Initiative, and it took women off of hormone replacement therapy unnecessarily. I will say that it did provide one thing. It really shed light on how harmful oral contraceptive therapy can be, and that form of oral hormone replacement. Looking at progestins, because the progestins are really what caused the bad outcomes. I bring this up because this study is what led to stopping hormone replacement therapy for women. And we have a whole generation or more of women that have not used hormone replacement therapy. And we've seen their cholesterol steadily go up as they've reached perimenopause, menopause, and postmenopausal years. Why is that? Why is it that their numbers went up? Well, it's because their estradiol went down and it wasn't replaced. When estradiol goes down, when women lose estradiol, it changes how fat gets distributed through the body. Instead of it going to the hips, lower extremities, thighs, or distributed throughout the body, it becomes centralized and goes into the abdomen and into the liver. Well, what happens when things go to the liver? Remember, we talked about how cholesterol comes from the liver. The liver is a central energy regulating organ. When the liver gets inflamed, it's going to start turning out inflamed compounds or dysfunctional compounds. Part of that is going to be the cholesterol. So when you get fatty deposition in the liver, which can happen just from being in menopause, LDLs start to go up. Inflammatory LDLs start to go up. You start to get metabolic disorders. You start to get glucose dysregulation. All this stuff starts stacking, and now you've got somebody that's not getting their hormones, their vascular system is not functioning well, their LDLs are going high, and then instead of getting back on hormones, which they should be getting on, they're going to get a statin, or they're going to get something to lower cholesterol. So we start getting this polypharmacy that just stacks on top of each other that's not addressing the root problem, which is let's give women their hormones. And that's what we really need to do.
Do you have any advice for that woman that is postmenopausal? She's on all those things. She's on her statin. She's gained the weight around the middle. We've tried the peptides. We've tried everything else. And is it too late for her to do hormones at that age?
It's never too late to do hormones. It's just a matter of how much benefit you can extract from it. What we've also learned from this population of women that had their hormones stopped is that once we get past 10 years, then the amount of benefit that they can recoup from starting hormone replacement therapy is going to be lower. The earlier it started, the better, because then whatever changes are happening can be mitigated nipped right at the bud, mitigated early on, and so you don't develop the metabolic abnormalities or problems downstream. When they've already developed, it's more difficult to turn the ship and reverse those problems. Doesn't mean that it's not possible, but it's going to take longer. It's going to take more dedication, and there's a chance that we may not get back to premenopausal status. It just still doesn't mean we don't use them, because there is a lot of benefit that can be had from using hormone replacement therapy, metabolic therapy like GLP-1s and GIPs, exercise, and anything else that we can do to tune up their health and inflammation again.
If we were talking to people and they could go out and buy 3 supplements right now that could help support their cardiometabolic health, what would they be? Which ones would you choose?
3 supplements right now, huh? Well, it depends on the person. If it is somebody that doesn't have any disease and they're looking for primary prevention, then we don't need to be too aggressive, but we do want to test and see what their risk is. My go-to supplements one is bergamot. I use that a lot for supplemental LDL management, either bergamot or something called citronol. Those two work really well together. Different mechanisms of action, but really function to reduce inflammation and improve cardiometabolic health. I've always been and continue to use omega-3 fatty acids. I think that those are really important in standard American diet. And even if you eat healthy, I think it's important. We don't get enough omega-3s, even when we think we are. And lastly, vitamin D, magnesium, these kind of supplements. We're still low in those. It's amazing how many people I still see coming in to the office on a daily basis with their vitamin D levels sub-therapeutic. And it's such a important foundational vitamin. I mean, it's more of a hormone than a vitamin. We do it a disservice.
Yeah, we do. It's like the master regulator of our hormones. I mean, you really need that. those are great because in a primary care, a healthy patient, that's exactly what we do here. Those are the supplements we want onboarded for them. They're important, and they also need to be managed and looked after, especially vitamin D. You can watch those levels and have those drawn. So I've talked about supplements. I want to talk about testosterone and TRT therapy for men and growth peptides.
Yes.
What we're seeing out there, do you see any danger involved with people self-prescribing this to themselves and taking TRT
Yeah.
as well along with it?
Well, let's start with the TRT.
Okay.
So for testosterone replacement therapy, I mean, I am a big supporter of using it therapeutically as well as for performance if necessary. The way the population that I see, most men are sub therapeutic in their testosterone, and I'm not pushing for excessive levels. I usually go for a total testosterone 750 to maybe 1200. And that's in with the caveat of looking at the free testosterone. That's also got to be upper range and normal. I rarely do anything that's super physiologic. There's a epidemic of low testosterone, and it's from increased stress. It's from poor sleep. It's from endocrine disruptors. You name it. The modern lifestyle is designed to destroy the testosterone in men. So I routinely replace it. And when you look at what testosterone does, it's not just about energy. It's not just about libido. Testosterone has receptors in every cell of your body except for the sperm and the egg. And there's a reason for that, because it is foundationally important for protein muscle synthesis, for inflammatory control. I mean, depending on the organ system, it will have a different effect, but it is one of our fundamental regenerative tools, along with estradiol. For men, it's extremely vital because that's how men get estradiol. That's how they get the healthy estradiol. If you have a lot of fat, if you're obese, that's another form of estradiol that you're going to get, but it's not going to be as effective, and it may be more pro-inflammatory. So men get a higher peak and a lower and a nice drop compared to women. Women tend to have a more even testosterone range, and so they don't function as well with high highs and low lows. So women also need testosterone to be replaced. So I do it for both and regularly. And I have no concerns about replacing testosterone in most of my cardiac patients, because I really understand what it's doing for the vascular system, and even for failing hearts, heart failure. We see that studies show that it can help with heart failure symptoms, with angina. Does not cause arrhythmias, does not cause hypertension, only if you're doing super therapeutic doses and you're doing bodybuilding doses, which is I don't recommend. So foundationally important for men and women. Now, when you add peptides on top of that, like growth hormone secreting peptides, secretagogues, it can increase anabolic drive. It can increase protein muscle synthesis. But if you're using peptides and secretagogues the right way, it won't cause any adverse issues. The right way is to pulse it, do them where it's about 8 weeks to 12 weeks on, 4 weeks off. You've got to give yourself a time frame off so you don't develop an adaptation to it, as well as with certain peptides like sermorelin, tesamorelin. If you use them constantly, then you can start to get glucose dysregulation, cortisol problems. And that's where, like you said, if you use them without the right guidance, if you just continue to use them, you can run into some metabolic problems. You can start to promote inflammation, cause issues that could easily be avoided if you just were doing it with an experienced practitioner. And then if you start adding other growth hormone agents in there, like synthetic growth hormone, that's when it becomes really problematic. Which is why I never recommend using synthetic growth hormone unless there's a medical condition like like juvenile growth hormone deficiency, where it's been FDA approved. Otherwise, secretagogues are the way to do it. The reason is because it's a very short-lived temporary burst of growth hormone, which your body can control. When you use synthetic growth hormone, it's a long-term exposure, more than 24 hours, that your body cannot control, and it causes these unwanted, hyper growth-oriented side effects.
When we talk about testosterone too, as well, I meant to ask, is there a specific delivery, or do they all work the same? Injectables versus topicals. With men, can men do troches as well? Can men do sublingual testosterone?
It's all very individualized, and it depends on how much we want to increase the levels. The two most common forms that I see are going to be topicals, topical creams, and injectables. But each has its limitations. There's no perfect form. You can get a topical cream, you can get injectable, a troche, a pellet. There's oral forms now. You name it. There's actually intranasal forms too. There's no shortage of it, and you're probably going to see, buccal absorbed forms in the near future too. So it's about how much needs to get delivered and how and the individual tolerance and absorption. So I'll go quickly through them and kind of give you a rough pros and cons. Topical has variable absorption and can be transferred, but you can get serum levels. It's a daily dosing. Next, troches, short-acting, rapidly absorbed. You might have to use multiple throughout the day, and the amount you can get delivered is probably lower. But it may be even a little bit more variable than a topical. Injectable is reliably absorbed. It's twice a week dosing, but it involves injecting yourself. And sometimes that's a challenge, especially if you're traveling a lot or don't want to do needles, or if you're on blood thinners. Pellets are once every 6 months. That's an in-office based procedure. Usually you get very high peaks and low lows with the pellet, and so that can be problematic for some people, and especially women. It can be very convenient, but once you get it implanted, you're stuck with it. And so that's also a challenge. Sometimes you can get the wrong dose put in, and then you got to deal with it for 6 months. And then oral forms, multiple day dosing. I think oral forms are still useful, but they got to be used for the right person. Not all of them do everything that they say they're going to do. There's different types of oral forms. I think that's enough for now.
Yeah. So the creams, though, can they move the needle?
Yes, creams can definitely do it.
Can move the needle for men that are wondering, can creams do it? Because a lot of people don't want to do the injectables, or it kind of throws them off. They don't want to be tied to that. But creams can do it. And one of the if you're married or you're dating someone, you just have to worry about that transfer. What advice would you give to your male patients on that?
I would actually recommend, if they are, so not everybody actually needs to get testosterone replacements.
Right.
There are many options to help stimulate our body's ability to make more of its own testosterone, and that would be the ideal situation if you're on the edge, young, and if you still want to have kids, whether you're old or young, then you've got to use other options like HCG, Clomid, or enclomiphene, and those figure out a way to, in different ways, trick your body or stimulate your body to make more of its own testosterone. And oftentimes you will need that in addition to testosterone, because if you take external testosterone, it will shut down your natural drive and it can inhibit your fertility. So if you're even thinking about having kids, then you've got to take both of those agents.
This is great information, Dr. Husain, for men, because I don't think there's a lot out there for men to listen to out there when it comes to the real information, the real questions about all the options, the things they can take, the risk factors, the different options. I think they think one way, and that is it's an injectable, and that's the only way, and that's the only thing I need. And there is an array of things that they can have access to that can actually help them be successful in their journey of longevity. Like you just said, if they want to procreate and have children, that's looked at completely different than the male that just needs TRT. That's older or wants that a little bit of anabolic. I think that testosterone helps with a little bit of anabolic growth, doesn't it?
Oh yeah, it does. Yeah, it's the original anabolic steroid. You know, it was
amazing.
that's what was used, you know, high doses of it stacked with other agents, but that's what the original, you know, bodybuilders were using. Yeah.
Mm-hmm. Well, it worked. Those original bodybuilders.
Yeah.
What else here? I know I've had a ton of questions for you. GLPs.
Oh yeah.
And heart health. We got to talk about that because that has really showed quite cardio protection for the heart. Share with us a little bit about the GLP-1s and GIPs and how they're important. Metabolic health is so important in our sexual health, in our heart health, and in our metabolic health.
Yeah. I love GLP-1s. I think that these medications have probably changed the fabric of our culture and our society more than any other medication has in recent memory. Prior to Ozempic being released, nobody knew what a peptide was, and everybody was scared to death of getting to have to inject themselves. You know, since Ozempic was released, everybody knows what peptides are, and people will take a shot to lose any amount of weight if they can. You know, I say that jokingly, but what it also does is there is so much data out there that looks at what GLP-1s have done. Now, these medications have been around for more than 10 years. They've been around. They've just been shorter acting, or they've been studied in preclinical studies, animal studies, but slowly but surely we've accumulated thousands of studies looking at the safety of GLP-1s, whether short-acting ones, long-acting ones, and or the newer generations, which are dual receptor agonists, GLP-1, GIP. At its core, what these medications do are signals. These are signals that our body sends to the rest of our tissue that we have food, we have energy available to be utilized. And so these are tools to tell our body how to utilize this newly found energy. Now, that can mean it could go to, if you have an inflammatory process, it could mean, it's going to go to inflammation. If you have cancer growing, it could go to cancer. This is what your body is trying to figure out on a day-to-day basis. Well, GLP-1s are the medications that help allocate that. So it's only released after you eat, and it gets quickly degraded. So we want to divert energy to our vital, necessary functions. That's what GLP-1s do. And when you think about it in that context, then it's understandable why these medications have so many other positive benefits. Because it's telling our body, okay, we have food, let's send it to the areas that are most important. Let's send it to our brain. Let's help our brain health. Let's reduce inflammation, and so we don't feed our inflammatory processes. Let's help our cardiovascular health. Let's feed the vascular system. Let's reduce our blood pressure so you can relax, so the system can calm down and utilize the energy that's coming to it. So it's not just, and it's also got to send signals to the brain, like to tell you, okay, I have energy. You don't need to eat anymore. I'm full. I should slow down my gut because I just have food that came into it, and now I need to spend time to let it digest and slow the movement down. So you can see why this receptor, this naturally occurring hormone, has so many wide applications, because it's directing where this new energy that you're consuming comes from. So on a more like specific nuts and bolts scale, what does it do for the vascular system? It reduces the inflammation of the vascular system, improves the flexibility of the arteries so that they are more pliable. It reduces the amount of immune compounds that grab onto the lining of the artery. And when we look at experimental studies, it does have an effect on cholesterol deposition and even potentially being able to reverse some of the plaque that's deposited. So when I look at what it does for just atherosclerosis, it's part of my toolbox of basic foundational therapies that I start a lot of my patients on.
It's amazing. It really is. I think you're right. You made a statement there that 6 months ago I wouldn't have felt the same way. And that is, we've gotten used to injectables now. We're seeing it everywhere. 6 months ago I would have thought there'd be a population of people that would only use oral GLP-1s. And now I don't think that's true. I think people feel completely different, and they're willing to try this, and they make it so simple when it's in the pens. So we've got a new one coming out too, a new oral, I guess. Is it this summer? It's
the previous oral compounds, the orals GLP-1, that was Rybelsus. And that was basically the same as the same GLP-1 compound, but they had it encased in something that was supposed to be able to penetrate the lining of the stomach and allow it to be delivered. Fairly effectively. There was a lot of limitations with how you could take it, and it wasn't as effective as they wanted it to be, but there were many adopters of it. This new form is a completely different chemical. It's not a peptide. It's a small, what was it? A small molecule.
Small molecules, yeah.
And so it's orforglipherol, and it's got great data to support it so far, and different mechanisms of stimulating that GLP-1 receptor.
That's awesome. I know. I think it's all great. Lastly, I'll wrap it up with lifestyle.
Yeah.
Lifestyle is super important. Moving your body.
Definitely.
Not moving it too much. I mean, people go from 0. They don't have to go to 10. Just move your body, right? If you're not moving your body, start there. Now there's the big talk of a hot sauna, which I'm a big fan of. I would love your opinion, though. It's something I walk my patients back from, telling them it can be a stressor as well, and you don't need to do it daily because everybody's buying their own saunas. And I don't know, I would like a cardiologist's opinion on if you think that it's something that should be paced, maybe a couple times a week, and do something else besides just hot sauna. I've got people doing it 7 days a week.
That's right. I don't recommend doing it 7 days a week. Well, I'd say the first thing is if you have certain heart conditions, we do want to be careful with saunas, because valvular heart conditions especially, but others as well, they can cause a significant strain to the blood flow and can cause adverse events. So cause a serious consequence. So just make sure that you don't have that and you're healthy enough. Usually if you're exercising well enough, then you're going to be okay. But it's important to get that evaluated. That being said, doing a sauna daily every day is basically like working out every day. A sauna is not necessarily a full, you could consider it a recovery, but it's not passive. You're still stressing the system. Mm-hmm. Stimulating heat shock proteins can cause a initial inflammatory reaction, but then it becomes anti-inflammatory afterwards. That's the same thing that exercise does. When you look at what happens physiologically, you're also increasing your heart rate, you're increasing your blood pressure, you're provoking a sweat response. These are all useful, but it's not something that it's going to be something that it's not a full recovery. It's not a rest day. So you're not going to want to do this every day after a workout. essentially what you're doing is you're increasing your metabolic load, and your system has to recover from each of these metabolic loads. So I recommend doing it probably 3 to 4 times a week at the most. And if you're going to do it, you've got to gauge what your exercise intensity is, because it's not something that is completely benign and passive. It is benign in the sense that it does a lot of really good things for you, and I completely support using it. It's just a matter of balancing it. So it's like you said, there's a you don't go from 0 to 10, and doing anything at a 10 is not something we should be doing consistently. Humans are really good at working in pulses. We can push ourselves really hard for a short period of time, but then we've got to swing back into a recovery mode. So we're very cyclical that way, and our physiology works best in a window for most of the time. It can be pushed for a short period of time and then come back to that recovery window. If you're exercising on a regular basis, and then that's like a push, and then you add a little sauna to that, that's like a little more of a push. So then every time you do that, it starts to add up, and it gives you less time to recover, more of a metabolic burden, and then you may start to see more fatigue, more injuries or things like that. So
Yeah, that's great advice. It's perfect advice. That's so true. And exercise is the same way, right? You can do HIIT, but unless you're an athlete, an extreme athlete, it's not something I would recommend to my average patient to just go out and do a HIIT class every day. Maybe once a week. Moderation, let yourself start there. Do some sauna. Do a lot of walking, movement, move the body, right? Do those things. And maybe don't jump into cold plunge right away.
sure, yeah. Yeah, cold plunge.
Brr.
Yeah, that's also very individualized. So they're going to be great for you as well, but they're a different stressor. So yeah, it's and as long as you can take it, it's not something you got to do every day.
Right. I like that. So it's a stressor just like working out is a HIIT class, but you can always walk, move your body, and if you're a female, I like to tell my females, you have to lift weights.
Yes.
It's easier for me to tell my male patients that because I tell them to walk and move their body because they already like lifting weights. But females, it's really good for us to lift weights and make that a priority of our workout.
Definitely.
It helps with our hormones. It helps with our diet, or our metabolism, I should say. And overall, I think it's heart healthy, right?
Yes, yeah, it is. It helps. Weight training is definitely a good way to improve your vascular health and your cardiac health.
Awesome. So thank you so much for being here today and giving me all this time. I had too many questions. I probably should have just done a few, and then we could have really broken it down. But I really appreciate you being here, and I know my patients are going to get a ton of info on this. Now, where can we find you? I know you're all over the place, Instagram, and I know you're in Boulder.
Yes.
And I know you have a license to practice medicine in California.
Yes.
Am I correct?
That is correct. Yes. Yeah. And so, I'm at Boulder Longevity Institute. You can find me at boulderlongevity.com. I am on Instagram, Dr._Abid Husain. There's also a YouTube channel which you can follow me on, and that is Dr. Abid Husain as well. I give a lot of information about cardiac prevention, and I actually do a lot of the discussion about these common modalities, whether they're cold plunge, sauna, GLP-1s, lab testing, a lot of information there. So you can find me there. Yes, I have multiple state license, so I can see people virtually, basically throughout the country, and I'm taking patients and happy to help people out. Love
Awesome.
the lectures, and thank you for having me. It's always a pleasure.
You're welcome. We're going to have all of his information in the short show notes. So if you have questions about your health, if you're unsure about if you have risk factors, or you just want to stay ahead of the game, please go in. You can get an appointment with Dr. Husain. His staff will pull everything. I think you have a team of people that can get everybody ready to see him, and then you guys can form a plan or decide what you need to do next. But the only way you're going to prevent cardiovascular events is by doing these types of things that he's doing and preventing them altogether. So there is a way to prevent heart disease, and he's one of the guys that has the recipe, one of the recipes. So thank you so much, Dr. Husain, and we will talk to you soon.
Thanks, Jerry. Talk to you
All
soon.
right. Bye.